So today we're going to start with one of the topics, oncology in general and hematology, malignancies. So in a couple of minutes, we're going to start. Before we start, any questions? If not, then we can start. So the green team has, I think one will be presenting today.
Yes, Assalamu alaikum.
Alaikum assalam wa rahmatullah.
Yeah, just apology for that. We didn't prepare for
That's
the meeting. I'm just going to read the topic of hematological malignancy. And if anybody that need to add anything and proceed with the other topics, it will be fine.
Sounds good.
Okay.
You can go ahead. Do you have the slides?
I will.
Yes.
Now you can see my screen.
Yes.
Okay. So the hematological, the oncological malignancy in older population. So in this presentation, we'll be able to describe the incidence and prevalence of certain cancers and how tumor biology and cancer behavior is modified by age, and how to assess the fitness and inform decisions regarding cancer treatment for older patients, and the risks and benefits of treatment approach of specific cancers in older adult population. So in this topic, we'll cover the cancer biology and aging, the principles of cancer management, and the assessment of the older cancer patients. Also the treatment options for older patients with cancer. This started with screening, chemotherapy, hormonal therapy, immunological therapy, biological and targeted therapies, radiation therapy, surgery, and the quality of life issues. Also, we'll cover specific cancers. This include breast cancer, lung cancer, colon cancer, gastroesophageal cancer, prostate, bladder, and renal cell carcinoma. Also, the hematological malignancies include lymphoma, multiple myeloma, leukemias, Hodgkin and non-Hodgkin lymphomas, and monoclonal gammopathy of uncertain significance. First, we'll start with epidemiology of cancer. Both the incidence and prevalence of cancer increases with age. There is one in 4 adults in the United States is caused, in the US is caused by cancer, deaths. The median age of cancer patient in the United States is 70 years. After age 55, heart disease becomes the #1 killer, and the risk cancer declines for unknown cause. In clinical trials of breast and colon cancer, it appears that treatment efficacy is similar in younger and older people who do not have significant comorbidities or functional impairment. So the reasons for the increased prevalence of cancer with age, some cancers are thought to develop over a long period, perhaps decades, and DNA repair mechanism may play a role. Decline with age, so cells accumulate and cause damage. The function of immune system also, particularly cellular immunity, seems to decline with age. And also older people are more likely than other adults to present with advanced stage cancer, and the epidemiological data do not support the notion that cancers in older people are less aggressive or slower growing. In the animal data, they do suggest reduced tumor aggressiveness with age. For most cancer types, the molecular biology and clinical behavior are similar across the age span. The ethnic aspect and differences in cancer epidemiology. Overall, Black Americans have higher rates of cancer incidence and mortality than any other ethnic group. So they found that cancer incidence is 10% higher than in white American, and also is the incidence is 50 to 60% higher than Hispanic and Asian American, and 50% higher than Native American. And the cancer mortality is 30% higher in Blacks than in the white American, more than 50 higher in Hispanic, Asian, and Native American. So in summary, the Black American with cancer have shorter survival times than white American at all stages of diagnosis. Relative 5-year survival rates are higher among people diagnosed at younger age than in those diagnosed at older age. There is 52% among Black Americans diagnosed before age 45, and 43% among those diagnosed after age 75. There's some data suggests that when quality of care is similar, outcomes for white and Black Americans are comparable. So the principle of cancer management, there is data from randomized clinical trials that establish the safety and efficacy of treatments for cancer have included few older patients aged 75 and over, and even fewer with comorbidities. New geriatrics-oriented trials are focusing more on symptoms reduction and quality of life outcomes than on life expectancy. Surveys indicate that when fully informed, most older patients choose life extending treatment, even at the risk of toxicity. Also in the principle of management, because of physiologic changes in older adults, there is potential for an increase in adverse events associated with treatment. However, acute toxicities may actually be less prominent in this population. Oncologists are often faced with the challenge of making management decisions in older adults in the absence of evidence-based guidelines. Appropriate treatment for cancer can be safe and effective in older adults if an adequate assessment is done and appropriate precautions are undertaken. In this aspect, the comprehensive geriatric assessment is considered the gold standard for evaluation of the older patient. Individualizing treatment decisions is important. The available guidelines for both the assessment of the older patient with cancer and treatment algorithms are in progress, and the National Comprehensive Cancer Network Older Adults Oncology guidelines are the most well developed. And this is the link for them. Also in the cancer patient assessment, in the cancer of older cancer patients, there is Karnofsky performance status and Eastern Cooperative Oncology Group performance. Measures are used commonly as they correlate with treatment toxicity. These tools alone do not predict outcomes in older adults, as well as comprehensive geriatric assessment. The geriatric assessment can detect issues pertinent to cancer management that would go unrecognized otherwise. Also, to take in the mind, the polypharmacy can increase the risk of adverse events from chemotherapy and increase the risk of non-adherence. So assessment of older cancer patients, there is factors that were independently associated with worse overall survival include low albumin, assessment performance status more than 2, and positive geriatric depression screen, advanced stage disease, malnutrition, advanced age. And I'm sorry that my kids are noisy a little bit, so I have to calm them down. So the assessment of older cancer patients. Hello?
Go ahead.
Yeah. The assessment, geriatric assessment, reviews the global health of patients, including functional status, comorbidities, cognition, nutrition, weight loss, polypharmacy, psychological status, social support, and geriatric syndrome. So to take all this in mind, there is variables within the geriatric assessment predict toxicity from the chemotherapy. Geriatric assessment require professional approach, which aids in developing a patient-centered treatment plan. So treatment option for older patients with cancer, current forms of cancer treatment include surgery, radiation, chemotherapy, hormone manipulation, and biologic therapy. Age alone does not preclude any of these approaches, but because of normal changes with age in certain organ and comorbidities, special considerations are warranted. So we'll start with the point of screening. Screening considered for breast, colon, lung cancer. Considered for breast, colon, lung, and in some cases, cervical cancer as well. Prostate cancer screening is controversial at any age and is unlikely to benefit someone. The prostate cancer screening is controversial at any age and is unlikely to benefit someone with less than 10 years of remaining life expectancy. Important to consider life expectancy and the risk of testing, over diagnosis and over treatment when recommending cancer screening for older adults. So assessing remaining life expectancy should involve comprehensive evaluation of health status and include functional impairment, disability, comorbidity, and geriatric syndromes. So we'll start with chemotherapy as a treatment option and mention some points and what's going behind this. The pharmacokinetic changes and in general, the impact in general is comorbidities and multiple medications add complexity. The pharmacokinetic changes, a progressive delay with age in the elimination of renal excreted drugs due to a reduction in glomerular filtration rate can contribute to more severe toxicity. Some drugs, example cisplatin, linezolomide, and capecitabine are contributed or need dose adjustment with renal insufficiency. The pharmacodynamic aspect, possible enhanced resistance with age to anti-tumor agents, increased expression of multi-drug resistance gene has been reported in some older adults. Increased tumor hypoxia with age has been observed in a murine model. The toxicity aspect, they include mucositis, cardiotoxicity, and peripheral and central neuropathies or neurotoxicity become more common and more severe with aging. Cardiotoxicity is a complication of anthracyclines and anthraquinone, mitomycin C, high-dose cyclophosphamide. The incidence of cardiotoxicity increases with age as well. Peripheral neurotoxicity with vincristine is more common and more severe in older patients. The incidence of cerebellar toxicity from high-dose cytosine, rabinocyte increases with age. The older population is especially susceptible to functional decline, confusion, syncope, and falls. Toxicity may have more serious functional consequences in older patients. Starting low, always this rule, starting low and going slow. is a reasonable approach with chemotherapy, especially for those with metastatic disease, for whom chemotherapy is palliative only. The myelotoxicity, chemotherapy-related myelotoxicity may become more severe and more prolonged with age, but moderately toxic treatment regime, such as CMF, cisplatin, and fluorouracil, and cisplatin and etoposide are tolerated by many patients aged 70 and older without life-threatening neutropenia, or thrombocytopenia. However, infections are marked increase among older acute leukemia patients undergoing intensive induction treatment. So in recent advances, granulocyte colony stimulating factor and granulocyte monocyte colony stimulating factor have reduced the incidence of neutropenic infections in patients receiving intensive treatment, and their effectiveness does not appear to be diminished with advancing patient age. Certain newer drugs or newer formulation may be particularly suitable for older patients. Example, oral etoposide, gemcitabine, vinorelbine, nab-paclitaxel, subcutaneous bortezomib, and liposomal doxorubicin. So now we are going to talking about the hormonal therapy. The hormonal therapy or hormonal treatment is effective in cancers of the breast, prostate, and endometrium. Most of these are well tolerated by older adults and commonly are the treatment of choice in this age group. Adverse effect should be considered in older patients. In breast cancer, tamoxifen is used as adjuvant therapy for breast cancer. It has estrogen-like positive effects on cardiovascular risk factors and bone disease. Aromatase inhibitors are also used as adjuvant therapy for breast cancer. More efficacious than tamoxifen and well tolerated, but it causes osteoporosis and fractures and common in patients on aromatase inhibitor. So prostate cancer, the hormonal therapy for prostate cancer, the first line treatment is for systemic prostate cancer, significantly decreased testosterone level and associated with metabolic syndromes, cardiovascular disease, osteoporosis, fractures, and physical performance decline or decrement. Older men can be subjected to adverse events of hormonal therapies for many years, given the indolent nature of prostate cancer. Prior to starting treatment include an assessment of life expectancy, prostate cancer severity, and overall health status. As we mentioned before, the assessment always the first. So the biological and targeted therapies, modulation of immune response is an attractive option in treating older patients who natural defenses may be impaired by immune senses. Recombinant alpha interferon used in melanoma, renal cell carcinoma, and hematologic malignancies. Interleukin-2 used with curative intent for advanced melanoma and renal cell carcinoma, but typically in younger patients. These agents have been supplanted by newer immunotherapy agents. Also, in targeted therapies influence the activity of a specific receptor involved in cancer signaling, and toxicities occur with monoclonal antibodies and targeted therapies, despite the thought that they are safer than chemotherapy. For example, ipilimumab and bimbrozumab and nivolumab, those are monoclonal antibodies associated with autoimmune mediated colitis and endocrinopathies. Rituximab and trastuzumab, monoclonal antibodies, generally have mild toxicities, but can cause hypotension or shortness of breath with ferrous infusion, which abate when infusion rate is slowed. Adutrastuzumab, imtacin, this antibody drug conjugates. This can cause systemic adverse effects, but more manageable. So the targeted therapies influence the activity of specific receptors involved in cancer signaling. For example, bevacizumab is a monoclonal associated with vascular adverse events given their mechanism of action, such as hypertension and thromboembolism. Tyrosine kinase inhibitors affecting EGFR and VEGFR pathways associated with vascular adverse events. So here are some agents and their adverse effects. These agents, in general, the adverse effect include hypertension and caused by, you can see here in the slides, they share the same biological origin. Those agents can cause hypertension, and some of them can cause QT prolongation, either high risk of QT prolongation or low risk of QT prolongation. This agent also can cause acneiform rash or maculopapular rash and hand and foot syndromes, keratoconchosis, other cutaneous squamous cell carcinomas, cardiotoxicity and decreased left ventricular ejection fraction. There is agent with high risks like anti-HER2 receptor, trastuzumab, or can cause just myositis, like BCR-ABL gene fusion agents. Some agent can cause peripheral neuropathy like platinum base or zinc alkaloids. Those can cause peripheral neuropathy. Some agent can cause myelosuppression and thyroid dysfunction also, anti-PD-L1 antibodies. Some agent can cause proteinuria, arterial or thromboembolic, those with affect the vascular factor. Electrolyte disturbances like potassium and magnesium disturbances. Those agents can cause like cisplatin, ventoklax, can cause electrolyte disturbances. Fluid retention also, one of the adverse effects, and dyslipidemia. The mTOR inhibitor can cause dyslipidemia. So now we're talking about radiation therapy. So published reports indicate that radiation therapy is safe and effective in older patients. For almost 5 decades, radiation therapy has been used as an alternative to surgery in poor surgical candidates, mainly patients more than 65 years. There remain concerns when treatment involves irradiation of the whole brain or pelvis, but no systematic investigations has categorically substantiated these concerns. The surgical options, age itself should not preclude effective elective cancer surgery, according to studies in both referral centers and community hospitals. Length of hospital stay and time to full recovery become more prolonged with advancing age. Advances such as endoscopy, spinal anesthesia, laparoscopic surgical technique, laser and photodynamic therapy, and new adjuvant chemotherapy, breast and lung cancer can benefit from this in older patients. The trend to manage cancer without deforming surgery may obviate complex rehab and be a special value to older people. So the quality of life issue, quality of life instruments have not been adjusted to the special need of old people. The length and complexity of some quality of life questionnaires may overburden some older people. Quality of life research might aid the choice between interventions yielding comparable survival. For example, measures of quality of life adjusted survival or quality adjusted time without symptoms or toxicity are important to consider for adults more than 70 years old. The research is needed in melding of geriatric assessment and quality of life instruments. So we are going to talk about specific cancer and the epidemiology of them. The 3 most common diagnosed types of cancer in women include breast, lung, and bronchus, and colorectal cancer. In men, prostate, lung, and bronchus, and colorectal cancer. So the breast cancer worldwide, nearly a third of breast cancer cases are seen in patients more than 65 years old, and is more developed in more developed countries. This proportion rises to more than 40%. Advanced age at diagnosis is associated with more favorable tumor biology, as indicated by increased hormone sensitivity at lower grades and proliferative indexes. Older patients are more likely to present with larger and more advanced tumors. The treatment option for breast cancer for patients with localized cancer, the evidence supports surgical treatment versus primary hormonal treatment. The breast conservation treatment consisting of breast conserving surgery, this includes lumpectomy or partial mastectomy, and post-operative radiotherapy is now recommended as a standard of care for patients of all age with early diagnosis, with early disease. Total mastectomy remains a surgical option for older patients who prefer it over breast conservation treatment, and for those who decline or are not candidate for post-operative breast radiotherapy. It should also be considered in patients with large primary lesions. So in women, a need for complementary axillary lymph node dissection after a positive sentinel node is found. And the data suggests that sentinel node sampling is just as accurate as axillary dissection, but considerably less toxic. The value of irradiation after lumpectomy. The local recurrence rate may decrease with age, and inconvenience cost of radiation therapy may outweigh the benefits. The value of adjuvant hormonal therapy is more than 2 years. So controversies also in the management of breast cancer. In older women, the initial management of metastatic breast cancer, women more than 65 years old with metastatic hormone receptor positive breast cancer are likely to have effective palliation with hormonal therapy. And chemotherapy has also been shown to be safe and effective in this group of patients, preferred first line in patients in visceral crisis. So the lung cancer treatment is tailored to cell type. The either small cell versus non-small cell lung cancer, increasingly common in older women for reasons that are not well understood. I think this is wrong. I think they mean that men, because smoking issue is more common in men than women. So most patients present with stage 4 disease, goal of therapy is palliative. For patients with lesions in a location that precludes surgery, stereotactic radiation can result in long-term survival. Over the past decade, chemotherapy has been shown to produce clinical response and provide effective palliation for abortion of patients with metastatic disease. Also, the first-line immunotherapy is also an option for patients with advanced PD-L1 high tumor with improved outcomes and less toxicity than with chemotherapy. The small cell lung cancer is often treated with chemotherapy and or radiation therapy without surgery, depending on the stage. The brain metastasis relapse is common in this type of cancer. Newer radiation techniques being developed to minimize long-term neurocognitive effects. So here, the colon cancer, is the third leading cause of cancer in the United States, second leading cause of cancer death. 2/3 of cases occur in people more than 65, and more than 90% of cases occur in people more than 50 years old. Women are more likely than men to harbor right side colonic adenomas. Colonoscopy should be performed in all cases of hematochezia, local GI bleeding, iron deficiency anemia, or even melena after a negative upper endoscopy. Colonoscopy has become the mainstay of prevention of colon cancer because it enables direct visualization of the entire colon and biopsy. Polyps may bleed or predispose to cancer. This include neoplastic polyps, adenomas, or non-neoplastic hyperblastoma, or old age and male gender are the major factor of bleeding as well. A 3-year interval for surveillance colonoscopy is safe and cost-effective for most patients with adenomas. For a small tubular adenoma, this will give it 5-year follow-up. For large villus, we'll give 1-year follow-up. And for negative screening or surveillance colonoscopy, we'll give 5 years follow-up. Patients with colorectal cancer should also have regular colonoscopic surveillance for adenomas starting 1 year after surgery, because these patients have adenoma or carcinoma recurrence rate of 25 to 30% at 3 years. Also, in colon cancer, the surgery, excisional surgery, may be adequate for lesions confined to the colon. But if regional nodes are involved, post-operative adjuvant chemo, usually 5-fluorouracil and leucovorin, has reduced recurrence by 40 to 50%. Age per se should not be considered a contraindication for surgery. For patients with localized rectal cancer, the standard of care involves a multidisciplinary approach. Stage 4 metastatic colorectal cancer standard of care includes systemic chemotherapy with or without antibody therapy and surgical intervention. For the gastroesophageal carcinoma, approximately 60% of esophageal and gastric cancers arise in patients more than 65 years old. Fit older patients with resectable disease should be considered for preoperative chemotherapy with radiation or preoperative chemotherapy in conjunction with surgery. Multidisciplinary approach, including oncology, radiation oncology, and surgery, is very important for the beginning, from the beginning of the decision-making process. In older patients with recurrent and metastatic disease, palliative chemo not only improves overall survival, but also improves quality of life. So in prostate cancer, the prevalence of prostate cancer in men is more than 75 years old, is over 1 million, with more than 60% of all new cases diagnosed in men more than 65 years old. Most men with prostate cancer die with it, not from it. Okay. But with increasing life expectancy, older men may experience symptoms from progressing prostate cancer. Watchful waiting is the most common approach for localized disease when life expectancy less than 10 years. Patient has significant comorbidities, or the tumor is small and well to moderately differentiated. So for these people, population will just watchful waiting approach. Advanced prostate cancer cannot be cured and affects patients whose disease has spread beyond the prostate and or are symptomatic. Patients with biochemical recurrence only arise in prostate PSA antigen with no evidence of disease. So androgen deprivation therapy is the initial management for these patients and is associated with numerous adverse events like hot flashes, sexual dysfunction, osteoporosis, metastatic syndromes, falls, and physical performance problems. So for the bladder cancer, age is an independent risk factor for development of transitional cell lung cancer. The median age of diagnosis is 69 years for men and 71 years for women, with the peak incidence at 85 years. With advanced age, there is an increased risk of detecting higher stage and higher grade cancers. When considering therapies for an older patient with bladder cancer, overall benefits should be weighted against adverse effects and remaining life expectancy. The renal cancer, the average age of at presentation is 64 years in both sexes. Currently, more than 60% of cases are diagnosed incidentally, compared with 1970s, when only 10% of cancers were found by chance. Thus, more patients are diagnosed with early disease. The treatment for local disease can be surgical, radical or partial nephrectomy, or ablative therapy. This includes radiofrequency and cryotherapy. The growth rate of small renal cell cancer is low, and metastatic disease occurs in 1% of patients. In asymptomatic patients or in patients who are frail with limited life expectancies, active surveillance can be proposed. So the hematological malignancies, acute myeloid leukemia. Acute myeloid leukemia likely to be refractory to treatment, have a smoldering course for which only supportive care is administered. Increasing age is a poor prognostic factor for AML, independent of cytogenetics. Patients with myelodysplasia who have no excess blasts or overt leukemia but are neutropenic and have recurrent infections may benefit from intermittent granulocyte colony stimulating factor. The value of immediate chemotherapy for older patients has been established, but choice of treatment remains controversial. Most common form of leukemia in the Western world, this AML, most common form, and median age at diagnosis is 61. Diagnosis is most often made incidentally. CLL. This is in the older population, more than 61, and diagnosis made incidentally. The treatment is generally withheld unless required to control a life-threatening or symptomatic complications, notably infection or marrow failure. About 25% of patients with CLL develop autoimmune anemia or thrombocytopenia, so investigate the mechanism of any decline in peripheral blood cell counts. The non-Hodgkin lymphoma, the prognosis worsens with age. Older patients may be more susceptible to the complications of intensive treatment. Diffuse large B-cell lymphoma and follicular lymphoma are the two most common forms. Outcome of CHOP therapy in diffuse large B-cell lymphoma appears to be significantly improved by adding rituximab. Treatment of follicular lymphoma is more controversial. This includes localized forms and are curable with radiation. The Hodgkin lymphoma age incidence curve is bimodal, with second peak late in life compared with younger patients. Older patients with advanced disease respond less well to the therapy and have shorter survival. Most older patients tolerate modified versions of ABVD-like chemotherapy without life-threatening bone marrow toxicity. Multiple myeloma and monoclonal gammopathy of uncertain significance. The classic triad of this is bone marrow plasmacytosis, more than 10%, lytic bone lesions, and monoclonal gammopathy in serum, urine, or both. Monoclonal gammopathy of uncertain significance is common in older people, must be distinguished from myeloma. Low risk of monoclonal gammopathy progresses to multiple myeloma or lymphoma is like 1% per year. Treatment required for symptomatic progressive lytic bone lesions, recurrent infections, or serum paraprotein increases. So in summary, the incidence and prevalence of cancer increase with age, and older adults more often present with advanced stage disease. Screening older populations for colon cancer, breast cancer, can lead to early detection of more curable lesions. Older patients can have less physiologic reserve than younger patients, but unless a specific comorbid illness is influencing baseline organ function, or cancer treatments with curative or palliative potential should be offered to most patients in most settings, regardless of age. In general, surgery, radiation, chemotherapy, and hormonal and biological therapies are safe and effective for fit older patients. Cancer treatment, especially chemotherapy, should be individualized with appropriate precautions taken relative to the patient's comorbidities, vital organ function, and underlying health status. This is best done with a comprehensive geriatric assessment and interpersonal approach. Choosing wisely, recombination based on the American Board of Internal Medicine Foundation's Choosing Wisely champion. Don't recommend screening for breast cancer, colorectal cancer, or prostate cancer with the PSA test without considering life expectancy and the risk of testing, over diagnosis, and over treatment. You have to consider all these factors. Assessing remaining life expectancy should involve a comprehensive evaluation of health status and include disability, comorbidity, and geriatric syndrome.
Thank you so much. You don't have to go through the cases.
Yes. Sorry again.
No, that's great.
I just see the slides. Okay.
You did great. I think we went through the slides, and it's very informative, and you're gonna see hopefully in your practice, guys, if you go through the residency, some rotations, one of them is hematology or oncology. You're gonna see some patients with these conditions. So the last slide, if you go back to the slide before, choosing is wisely. So the idea is to think about not only diagnosing the patient, but what are you going to do after that? So patient with cancer, if they don't wish to go through the chemo and all the other options, then it's better not to do the screening and find the cancer and then go through the hassle of informing the patient, and the patient will say, no, I don't want to live longer or something like that. So it's better to understand the concept of what the quality of life, what the options for treatment of certain type of cancer, and then treat your patients with some thinking ahead, so that you don't end up with over-diagnosing or over-treating patients. This is why in the past they didn't consider like CT scan for lung cancer, because they will have a lot of positive findings. Some of them might not be true, and they will end up treating a lot of patients with chemo or radiation or other surgery for not real cancer. So the same with prostate cancer. In the past, they were recommending yearly testing and PSA and following this and that, but this has been changed for some time, the recommendations, because they don't want to overdo it for cancer that the patient in the past, like one of the slides mentioned, the patient with prostate cancer can die with something else, heart attack or some other type of cancers, but not from the prostate cancer. But with advanced technology and treatment and management, nowadays people are living longer. So this recommendation has changed a little bit. So people are saying patients with prostate cancer, for example, they may have some spreading of the disease. So again, you want to talk to the patient, see what they are wishing, what their wishes are, and then do the planning accordingly. But thank you so much. I really appreciate your presentation.
Thank you, Doctor. So I will proceed with cases or?
No. We can skip the cases for now.
Okay.
But I really appreciate your input, your stepping up and presenting.
Thank you.
And just for the other people, it's the same what she did. Some of these slides are already there. So we want you to, if you don't have time to prepare, you can do it on the fly. We can just put the slides and you can read it and you can benefit others. For you guys, it's going to be something that you did for the group and it's beneficial teaching others. But for you, you might experience or you might benefit from increasing your confidence in yourself. You can put this in your CV, or you can talk about this during the interview that you presented to this group in a teaching method or something. And this happened when hopefully you join the residency program and fellowship down the road. You will be asked to present some topics, either case or topic in a small group or in large groups. So this is an opportunity for every one of you. So thank you so much. I really appreciate it again.
Thank you, Doctor.
All right, for the next part, maybe Dr. Ali and Dr. Amal will go over some of the common cerebral rashes that we can see in some of the patients. So maybe we can cover some of the other topics as well. So when you are ready. Any questions or comments regarding the previous topic? If not, when you are ready, Dr. Ali, you can go ahead, and Dr. Amal.
Hello, everyone. Good afternoon.
Good afternoon.
Just give me a few seconds to share my screen and can I start the presentation?
Sounds good. Thank you. And again, I'd like to thank Dr. Ali and Amal because I just mentioned to them that someone can present and they jumped in and would like to help us today. Thank you, both of you.
Yeah, it's our pleasure.
Dr. Ali, if you have any problem, I can share my screen for you.
I think, yeah, just give me one second. I think my laptop is hanging. Okay. Can you guys see the screen now? Can everyone see my screen?
Yes, it's processing.
Can see it now?
I can't see.
You can't see the screen?
Oh, no. Yeah, now it's clear.
Yeah.
Okay, perfect. My voice is clear?
Yes, it's clear.
Okay, that's good. Okay, assalamu alaikum everyone. Good afternoon. My name is Ali. I would like to present to you with my colleague Dr. Amal about 10 causes of a circular rash. Okay. When talking about a circular rash appears as a round red circles or ring-shaped spots on the skin. One of the most common causes of this is the ringworm, which is a fungal infection. Okay, we will be talking about the ringworms and also other 9 common causes of a circular rash. And we will also present with some pictures to help us understand the diseases. Okay. The first thing is the ringworm, which is an infectious fungal disease. Okay, this is a picture of a ringworm which appears as an erythematous macule or a patch. Okay, with surrounding scales. Usually, how we describe it is a red, pink, or a brown circles on the skin. It can appear on any part of the body, and according to the part, the naming of the disease is different. Okay, and it's usually very itchy. So when we have like ringworms on the body in general, we call it tinea corporis. Okay, but if we have it on the groin, it's called tinea cruris. If it's on the hand, it's called tinea manum. If it's on the scalp, it's called tinea capitis. Like I said, it's a very itchy disease. Okay, and it appears as a red circular rash with central clearing, and on the edges of the rash, usually there are scales. This is how we identify the rash. Usually the fungal infections have some certain risk factors, like to get the fungal infection, either you get the contamination from someone who has the disease, or the other thing is by contacting a contaminated area. Okay, this usually happens like in public bathrooms, in public swimming pools and stuff like this. So the risk factors for having a ringworm infection are these, like the humid environment, weaker immune system, diabetes, excessive sweating, using public showers or gym rooms. All these are risk factors for someone to get the infection. How we treat it, usually the ringworms, like I said, it's a fungal infection. And to treat most of the ringworm infections, we use topical antibiotics or topical antifungals like clotrimazole or terbinafine, except for tinea capitis, which is resistant to the topical agents, and we have to use oral agents. The second disease, the second erythematous disease we have is the hives, also called urticaria. And it's usually an allergic reaction of the skin. Hives usually occur due to an allergic reaction of the skin. It happens due to many causes. Like many people have different causes of allergy, which results in urticaria or hives. And it is described as a red or a skin-colored spots. It can appear on any part of the body, and it's usually itchy. The urticaria or the hive can present as circular bumps on the skin, which may be red, skin-colored, or light brown. Okay. Also, one of the characteristics of urticaria is that they are blanchable, which means when we press on the rash, okay, it disappears or it turns white or pale. And then suddenly when we lift the pressure up, the rash will become red again. Depending on how long it lasts, we can divide it either into an acute or a chronic urticaria. The acute urticaria is a condition that occurs up to 6 weeks, and chronic urticaria is when the rash takes 6 weeks or more. Like I said, there are many causes of urticaria. and it's mainly an allergic reaction caused by histamine. Okay, people have different triggers for urticaria or allergic reactions. For example, medications, animal dander, dust, mold, infections, or certain foods like nuts, seafoods, eggs. There are a lot of causes. In some cases, it may be associated with facial throat swelling, and in these cases, we call it angioedema. Some people have hereditary causes of angioedema, and some people, they acquire the angioedema in their life. Sometimes the allergic reaction can be so severe, it can result in chest tightness, difficulty breathing, dizziness, and confusion, and people may need to be hospitalized for such symptoms. According to the severity of the condition, we prescribe the medications. For example, if the patient is just having hives or urticaria, we can give them oral antihistamines, okay, to relieve these symptoms. But if people have a severe allergic or anaphylactic reaction, we need to give them an epinephrine injection. Okay, usually we give the injection as an IM, and we can repeat it multiple times according to the response of the patient. But usually for just urticaria or minimal hives on the skin, the patient can take oral antihistamines and that's it. And sometimes even just topical antihistamines can do the trick. The third disease we have is psoriasis. Okay, psoriasis is an autoimmune disease. The rash is described as raised, round, red patches or bumps. It commonly involves the elbows, knees, scalp, chest, and back. It can be itchy, not all the time, but it can be itchy. Psoriasis is a chronic disease. Like I said, it's an autoimmune disease. And in some people, it has a form of a genetic or a family predisposition to cause the disease. It's characterized by increased cell turnover. The symptoms, they vary depending on the type of psoriasis. Like some people, they have plaque psoriasis, which appears as raised plaques, okay, which are oval or round in shape with scales, with silvery white scales on top. It may be associated with itching, like I said, and the most common areas involved are the elbows, knees, scalp, and trunk, mainly on the flexor aspects of these areas. The exact cause of psoriasis is not clear, but genetic factors, immune system, and environmental factors may play a role. Any injury, infection, stress can trigger an outbreak. And one of the important things to know, like some people, they have, especially in the general population, they have an idea that psoriasis is an infectious disease or it can be transmitted between people, which is a false idea. How to treat psoriasis depends on the type of psoriasis. For example, if we have just plaque psoriasis, we can treat it with topical agents. Okay, we can use topical steroids, immunosuppressants, vitamin D or vitamin A. But if people have an advanced disease or a systemic psoriasis or a psoriasis that involves the joints, we need to give the patients oral systemic agents. Sometimes phototherapy may be needed if the disease is progressive. The fourth disease we have is pityriasis rosea, okay, which is an infection that appears as a red oval or a round spot, usually involving the trunk, and it can be itchy. Pityriasis rosea can present with a red silky rash. People usually have a prodrome of flu-like symptoms like fever, malaise that may precede the rash. The initial red patch that appears is known as the herald patch. This oval and circular patch can reach up to 10 centimeters in diameter and typically appears on the chest, back, or the abdomen. 2 weeks following the initial rash, usually people will develop smaller red areas that can appear similar to a Christmas tree. Usually these spots are widespread and usually involve the trunk, arms, and even the thighs. And it may be associated with itching. The exact cause of pityriasis rosea is unknown, but some theories suggest that it's associated with certain viruses, like the herpes virus type 6, or sometimes by some medications. How we treat it, the rash is self-limiting and usually clears in 6 to 10 weeks. If the itch is severe, we can prescribe antihistamines or steroids to help with the itching, but the disease itself is self-limiting. The fifth condition we have is Lyme disease. Okay, Lyme disease is an infection caused by bacteria. Okay, usually it presents as a ring-shaped lesion with a bull's eye appearance, and it's usually not itchy. It can be located at any part of the body. Okay, it's called by Borrelia bacteria. Okay, and it occurs and it's transmitted by tick infection. Tick is the only transmitter for the disease, so it cannot be transmitted between humans directly. So a tick has to transmit after the tick bite, and even the tick bite, it has to be prolonged for a certain period. Like sometimes if you remove the tick before it takes like a certain period, the patient can avoid having the disease. Some people can develop flu-like symptoms like headache, fever, chills, or joint pain, or even enlarged lymph nodes. Around 70% of patients develop a skin rash that present as a red circular spots. It's called erythema migrans. Usually the center of the bite has a red spot where the tick bit the skin. This is surrounded by a clear zone, followed by an outer ring that is also red. It has a bull's eye appearance, reminiscent of a red circle with a dot in the middle. In some cases, the area may appear uniform in color, presenting as a red circular patch. If left untreated, it can involve several other organs in the body, like the heart, the CNS, the eyes, and sometimes the joints. Late symptoms of Lyme disease may involve chest pain, abnormal heart rate, arthritis, nerve pain or numbness, headache, dizziness, facial paralysis, and vision loss. How we treat Lyme disease? It's treated with antibiotic. Okay, we give the patients penicillin or doxycycline, depending if the patient is pregnant or not. And the outcome is best if treated in the early stages of the disease. Thank you, everyone. And that's all. I think my colleague Amal will resume with the rest, and we can take questions about the presentation in the end. Thank you all.
Thank you so much, Dr. Ali. I'll start by sharing my screen.
Perfect. Let me stop sharing.
Can you see my screen?
Yes.
Yes, go
Okay,
ahead.
great. Thank you so much, Dr. Ali, for the great presentation. I'm going to continue on with the rest of the annular rashes that affect the skin. So we have number 6, the nummular eczema, also called discoid eczema or discoid rash. So the key features of this rash is that it appears like red coin-shaped lesions and usually involves limbs and trunk, and it may or may not be itchy, but it's usually itchy, and I think it's more common in adults than in children. So it appears as dry, circular, or round patches on the skin and can be due to, like the differential diagnosis can be due to discoid eczema or nodular dermatitis. I think they are the same. Discoid eczema is the same as nodular dermatitis. So discoid eczema begins as small red bumps that merge together to form red or pink coin-shaped spots. On darker skin tones, these spots may appear brown. So it depends on the complexion of the skin, and they typically range in size from 1 to 10 centimeters and may exude clear fluids, just like other types of eczema, and may exhibit a scaly or crusty surface. These spots are often accompanied by itching. Just like any other type of eczema, it's usually itchy. Discoid eczema predominantly affect the legs, arms, or trunk, while the face and scalp are usually unaffected. And this is the photo of a typical nodular or discoid eczema. So what are the causes of this rash? So the exact cause is not known, but it may be associated with the following factors. It may be triggered by an injury, dryness, allergies, irritating soaps, poor circulation in legs, dry environment, rough fabrics, or certain medications. How to treat this condition? So the treatment includes restoring the skin barrier and avoiding further skin irritation. Gentle skincare with thick emollient moisturizers can be beneficial. So your doctor may prescribe, or doctors may prescribe the following medications: topical steroids, antihistamines, systemic steroids, and light therapy. So the treatment, as you can see or as you can notice, it's not different from the treatment of other types of eczema. So here we have number 7, contact dermatitis. And I think you're all familiar with that. We have 2 types of contact dermatitis, 2 main types. The first one is allergic contact dermatitis, and the second one is irritant contact dermatitis. So the main difference is that allergic contact dermatitis involves like immune cells are involved in the pathogenesis of this type, like T4 helper cells and T cytotoxic cells. But in irritant contact dermatitis, it's usually not involved. So what are the key features? It appears as flat red spots or bumps. So this is, we're talking about the allergic one mostly. Location, it can be located in any part of the body, depending on which part of the body was exposed to the specific allergen. Is it itchy? Yes, it's usually itchy. So it appears as red, itchy, circular rash on the skin when it comes in contact with any round object that contains skin irritants or allergens. So what are the causes? We said that contact dermatitis can be of 2 main types. The first one is the allergic type. It occurs when the skin comes in contact with an allergen, like a round pendant or other jewelry like nickel, poison ivy. So nickel contact dermatitis is a very common type. And also we have the irritant contact dermatitis, the other main subtype of contact dermatitis. It can occur when the skin comes in contact with an irritant, which can damage the skin barrier. So the difference, as we said, that allergic contact dermatitis is immunity is involved in that. So after the first exposure, it takes about maybe 2 to 3 days for the initial symptoms to develop. But irritant contact dermatitis, like the substance itself, causes damage to the skin barrier. So the damage is usually instant. It doesn't take much time. So examples of common irritants that can lead to irritant contact dermatitis include fragrances, essential oils, surfactants, and etc. So how to treat this type? The most important treatment in any type of allergy, whether it's a skin allergy or even including other types like, let's say, for example, asthma, the most important thing in any allergy is to avoid the allergen. This is the most important thing to start with. And other steps in treating allergies or contact dermatitis is to use gentle skincare products, avoid metal jewelry with nickel in patients with nickel dermatitis, and apply a cool compress. Antihistamines and topical steroids may help in decreasing these symptoms. So let's move on to the eighth type of annular dermatitis, which is the granuloma annulare. What are the key features of this condition? It appears as red spots in the form of rings, commonly involving the feet, hands, or fingers, and it's usually not itchy. And this is the picture of granuloma annulare. So what is the pathogenesis of this condition? It is an inflammatory skin condition that is of various types, with the localized form being the most common. It can be disseminated or localized, but the localized form is the most common one. And this type of granuloma annulare, the localized one, can present with red rings on the skin. So the surface of these spots is usually smooth, it's not raised, and the center may be slightly depressed. This type of granuloma annulare is usually seen in children and young adults, and it usually does not itch or hurt. So it's usually asymptomatic. So there are few other types that are less common, like the generalized type, which is seen in adults and can be itchy. So the localized type is seen more in children, and the generalized type is seen more in adults and can be itchy as well. What is the cause of this condition? The exact cause is not known. The participating factors include injury, insect bites, infections, medications, or sun exposure. It's commonly seen in females and people with diabetes, thyroid disease, or HIV. So those are associations, but the exact cause, the exact pathogenesis is not yet known. How to treat this condition? These spots usually resolve over time. However, treatment can help in clearing them faster. So the common treatments to this condition include topical steroids or calcineurin inhibitors, which are basically immunosuppressants, oral medications like steroids or anti-malarials, and we have also steroid injections, freezing or laser, which are topical treatment applied to the skin. Let's move on to lupus. Lupus can present with a wide variety of skin manifestations. So in the acute phase of lupus, or we call it acute lupus, it presents with like the butterfly rash, alongside other manifestations like acute arthritis, pleuritis, like myocarditis or pericarditis. And we have the subacute cutaneous lupus, which present as red raised circular scaly spots that are usually generalized, unlike the butterfly rash. And the chronic form of lupus or cutaneous lupus is called discoid lupus, which is a red scaly plaques, which can usually lead to scarring and hair loss. So what are the key features? Appearance, it appears as red spots, which may appear in the form of rings, usually sun-exposed areas. It's well known that lupus rash or lupus patients are usually very sun sensitive or radiation sensitive. Is it itchy? Chronic and subacute types are usually not itchy, but the acute type, which is the butterfly rash, may or may not be itchy. So cutaneous lupus is a group of disorders that affect the skin, and some cases of skin lupus may be associated with SLE, and sun exposure can make it worse, as we said. So let's dive deeper into the three main types of cutaneous lupus. The first one is the acute, and it presents with butterfly rash. The second one, the subacute cutaneous lupus, it presents with red raised circular scale spots, which may resemble psoriatic patches. It's commonly seen on sun-exposed areas like the upper arms or trunk, And how we can differentiate this from psoriasis, of course, the appearance of the lesions, but also the most important thing is to take full history and physical exam, and most likely other manifestations of SLE will be identified. So the third type or the third subtype of cutaneous lupus is the chronic cutaneous lupus, which is the most common type of chronic cutaneous form. The most common type of chronic cutaneous lupus is the discoid lupus. It's present with red and scaly patches or bumps in a circular pattern, which can lead to scarring and hair loss. And most commonly affected areas are the scalp, ears, cheeks, nose, and lips, and it usually leads to scarring and hair loss. So what are the causes of cutaneous lupus? So genetic, environmental factors, and the immune system may play a role. It's more common in females, as it is the case with most autoimmune diseases, and usually occurs between ages 20 to 50 years. How to treat this? So for any lupus patient, they have to protect their skin from sun exposure using a broad spectrum sunscreen. This is a very important step. And also of great importance is to avoid smoking. And sometimes some medications are prescribed, like topical steroids, oral steroids, anti-malarials, or immunomodulators. So the treatment of the rash itself does not differ significantly from the treatment of the entire condition. They usually take the same medications that lupus patients take. The 10th rash we have is the syphilis. And here we're talking about the secondary syphilis rash. So this rash is characterized by involving the palms and soles. And I think there are only a handful rashes that can involve the palms and soles. And it's important to know all of them so we can make a differential diagnosis whenever a patient presents with rash involving the palms and soles. Do you know any other rashes that can involve palms and soles other than secondary syphilis? I need your answer.
Kawasaki.
Yes, I think so. What else?
Kawasaki.
Yes, Kawasaki disease is one of the rashes that can involve palms and soles. Like it can present with desquamation. Yes, you mean the Rocky Mountain spotted fever?
Yeah, rickettsia and Rocky Mountain are the same. Rickettsia causes Rocky Mountain.
Yeah. And also, I think HIV as well. Not sure about that. And also hand, foot, and mouth disease.
Yeah, Coxsackie A. You're right.
Yes. So talking about syphilis, it presents with red, round, or oval spots or bumps on the trunk, palms, and soles. So it's basically generalized rash, doesn't involve a specific area. It's usually not symptomatic and not itchy, but the patient, of course, have other symptoms, like they have flu-like symptoms, fever, fatigue, headache, and so on. So syphilis is a sexually transmitted disease that can present at different stages depending on the progress of the disease. We have the primary syphilis, secondary syphilis, and tertiary syphilis. In the primary syphilis, it starts with a painless, firm, round sore, which is called the chancre, appears on the genitalia, and usually heals in few weeks. And usually it go unnoticed. This is followed by the next stage, which is the secondary syphilis, which typically occurs 3 to 8 weeks later. During this stage, red or reddish brown oval or round spots may appear on the body, and these spots can feel scaly and rough to the touch. And I think this term is called like maculopapular rash, and it usually involves the trunk, palms, and soles, as we said. It may be accompanied by systemic symptoms like fever, malaise, or enlarged lymph nodes. This is important and it can help differentiate secondary syphilis rash from other types of macular or other causes of maculopapular rash. So if left untreated, it can progress to tertiary syphilis and can affect vital organs of the body. It can cause like syphilis vasculitis and other manifestations if progress to tertiary syphilis, and also can affect the central nervous system. So it can have detrimental consequences. So it's very important to identify secondary syphilis, although it's rare, but it's still like should be within our differential diagnosis. So what is the cause? Syphilis is caused by a spirochetal bacteria. It's called Treponema pallidum. It can be transferred by direct contact with the lesions, and a pregnant female can transfer the infection to the baby. How to treat? It's treated with antibiotics. The antibiotic of choice is penicillin, and it's important to treat it in the early stages to prevent long-term complications. So this is a side note for patients, telling patients when to see a doctor. So patients should see a doctor if the rash involves large area of the body, if it is painful. This is not specific for the syphilis, it's specific for all 10 types of rashes that we have talked about. So if the rash involves a large area of the body, is painful, has a visible discharge, accompanied by other symptoms like fever or confusion, dizziness, headache, joint pain, occurred after a tick bite, which raises the possibility of Lyme disease, maybe also Rocky Mountain spotted fever. So the rash doesn't go away, and you're not sure what caused the rash. So all these are alarming symptoms, and patients should see the doctor right away. So what are the key points? A circular rash often makes us think about ringworm, which is a fungal infection. However, several other conditions can lead to red circular rashes like eczema, contact dermatitis, Lyme disease, syphilis, inflammatory skin conditions, lupus or granuloma annulare. So the take-home message is, and what we have learned from this lecture is that we have to consider all 10 differential diagnoses, all 10 types of rash whenever a patient presents with annular rash. So some of these rashes go away on their own. However, some need treatment to prevent long-term complications. And for patients, if they are not sure what is causing the circular rash, it's best to see a doctor who can help identify the cause and recommend appropriate treatment. So these are the references for the presentation. Thank you so much for listening. And please feel free to ask if you have any question.
Thank you both, Dr. Ali and Dr. Amal, for great presentation. So next we can go to the next topic, and speaking about syphilis, so the treatment is penicillin, but what about people who have penicillin allergy? So the next topic will handle this. Dr. Alaa, Omer, Alaa, when you are ready.
Hello, everyone.
Hello. And Dr. Alaa also volunteered to speak about this topic on the spot. So thank you so much for your help.
Thank you for this opportunity. But just give me a minute to share the slide.
Sounds good.
Now my slide is clear.
Not yet.
Okay, just I'm so sorry for this interruption. Okay.
Do you mind if I share the screen and you just let me know when I?
Yeah. Yes. I think now my screen is appearing. I have a problem. So sorry.
So can I just share the screen here, if you don't mind, and you just tell us?
Okay. Hello everyone. My name is Dr. Alaa Osama. I will present penicillin allergy assessment. The overview of beta lactamase, beta lactam, and the importance of penicillins, penicillin allergy and impact, strategies for penicillin allergy delabeling. So, beta lactams are the most commonly used antibiotics group in the US. Beta lactam ring core structure, variable side chains at the R side, different side chains, different spectrum of activity and duration of action. Penicillin class antibiotics like amoxicillin, ampicillin, clavulanic acid, ampicillin, sulbactam, dicloxacillin, oxacillin, nafcillin, penicillin, piperacillin, tazobactam. So in CDC 218 penicillins use about 59 million prescriptions. So penicillin drug allergies, 10% of the population reports a penicillin allergy, but less than 1% of the world whole population is truly allergic. So why are patients not truly allergic? So most studies report only a third of patients can describe their allergic reaction. Unrelated symptoms attributed to penicillin, rash with concomitant viral infection, and immunoglobulin E mediated penicillin allergic wanes with time. So why do we want to eliminate penicillin allergy from patient records? So cause of the penicillin allergy. Due to the cost of the penicillin allergy, cost to the patient, providers are focused to prescribe broad-spectrum antibiotics, increased rates of adverse reactions, higher rates of multi-drug resistance organism like VRE 30.1%, C. diff 23.4%, MRSA 14.1%. Also, the cost to healthcare, increased rate of hospitalization, prolonged lengths of hospitalizations, antibiotic alternative are more costly. In patients 0 to 609 penicillin allergic patients, in outpatient 14 to 193 penicillin allergic patients. So let us talk about the cell and Coombs hypersensitivity reactions. We have four types. Type 1, rapidly progressive, potentially fatal, and becomes more severe with repeated exposure. It takes minutes to hours. Mediated by IgE, presented with urticaria, rash, angioedema, wheezing, edema, hypotension, and anaphylaxis. Type 2 with variable onset, hours to days, mediated by IgG and complement hemolytic anemia, 1 in a million, neutropenia, 2 to 15% million, thrombocytopenia unknown. The type 3 reaction, it takes 1 to 3 weeks post-exposure, mediated by IgG and IgM complexes precipitate in tissues, present with drug fever, immune complex glomerulonephritis, and serum sickness. For 7 to 40 per 100,000 prescriptions. The type 4 delays days to weeks, mediated by T-cell mediated delayed hypersensitivity reaction, presented with contact dermatitis, Stevens-Johnson syndrome, toxic epidermal necrolysis, eosinophilia, and immune hepatitis. What is the metabolites in penicillin allergy? Penicillins are rapidly metabolized into penicilloyl, major determinant of penicillin allergy, accounts for the metabolism of more than 95% of native penicillin. Benzyl penicilloyl binds to protein conjugate, potentially immunologic heptans. Remaining metabolites of phenolate, penicilloate, and native penicillin, major determinants. Hypersensitivity to one determinant doesn't typically result in cross-reactivity to another determinant. Allergies to slide chains are possibly amoxicillin and ampicillin. So what about the cross-reactivity among beta-lactamase? With cephalosporins widely cited 10% from publications by Tench and Pitts overestimated through cross-reactivity. True cross-reactivity is estimated to approximately 2 to 3%. In vitro studies has shown that cephalosporin side chains constitute the major determinants of cephalosporin allergy. With carbapenem, less than 2% rate of hypersensitivity reactions in patients with IgE-mediated penicillin allergies receiving carbapenems. So, evaluating penicillin allergy, there is qualifications for penicillin allergy assessment, inclusions and exclusion. Inclusion: any IgE-mediated allergic reactions and tolerance that is listed as an allergy. The exclusion: severe risk allergy, like severe exfoliative dermatosis, Stevens-Johnson syndrome, toxic epidemiolosis, serum sickness, stress syndrome, thrombocytopenia, hemolytic anemia, hepatitis, and nephritis. Intolerance to penicillin class antibiotic that is correctly identified as an intolerance. So, how can a penicillin allergy be delabeled? Get an accurate allergy history. When the reaction occurred, timing of reaction in reaction to drug administration, in relation to drug administration, what infection was being treated, any potential confounders underlying viral infections, symptoms experienced, what treatment administered, response, and duration of reaction. Was the medication or similar medication taken and tolerated thereafter? So, About risk history stratification, there is four classifications. Not allergic, demonstrated evidence, or patient report of receiving and tolerating a penicillin class antibiotics since initial reaction. This delabeled penicillin allergy and so delivered penicillin allergy and educate the patient. The second one, low risk. There is a family history, unknown reaction more than 10%, more than 10 years ago, itching without the rash, patient denies allergy, but is on record, delayed onset cutaneous reaction in childhood. Allergy referral for oral amoxicillin challenge. The third one, moderate high risk. There is urticarial, pruritus, rash, IgE-mediated reaction, excluding anaphylaxis. Recurrent penicillin reactions, hypersensitivities to multiple beta-lactams. So, allergy referral for penicillin skin test and oral amoxicillin challenge if reaction occurred more than 5 years ago. The last one, severe risk. There is Stevens-Johnson syndrome, 10, serum sickness, stress, thrombocytopenia, hemolytic anemia, hepatitis, nephritis. No testing, penicillin allergy remains future use contraindicated. Now we will talk about penicillin skin test and oral challenge. We have a skin scratch test, a small drop of 4 reagent placed on forearm. If histamine positive, normal saline negative, pre-pen, and penicillin G. 4 drops of these 4 agents. Then scratch through drop using testing device. Measure results after 15 to 20 minutes. Continue to intradermal test if positive, histamine test more than 5 millimeter while and all other reagents are negative. Then intradermal test and oral challenge. What to do when a patient has an allergy to piperacillin, niftacillin, or amoxicillin, but can tolerate penicillin. Update allergy history to include all pertinent details in addition to what penicillin class antibiotics patient has tolerated. There is chart review tips. Searching the chart for administration of penicillin class antibiotic, class review and meds staff. You will change current meds only antibiotics and check current select antibiotic, score through listed inpatient and outpatient orders. Inpatient order can verify administration. Outpatient inquire if patient remembers taking. Search in search books for penicillin or antibiotics for index reaction.
So I'm gonna just jump in here. So in certain EMR, EPIC, for example, there is a way to identify patients who have allergy or they had listed allergy, and you can unclick that or you can fix the chart. So if you ask the patient the questions that mentioned in the earlier slide, you can clarify what type, what kind of reaction, and you can put that in the chart so that if you need to give penicillin, you have specific conditions you look at, and then you either go ahead or you switch to something different. Sorry, continue.
Okay, no problem. Qualifications for labeling. A patient caregiver is confident that he or she has tolerated penicillin, a penicillin class antibiotic since the index reaction. Ideally, this should be verified through a field history or inpatient administration, documented administration in the EMR of a penicillin class antibiotic that was tolerated since the index reaction. If patient has a history of an intolerance like GI upset, chills, headache, fatigue, that is listed as an allergy or adverse reaction, the EMR should be updated to reflect an intolerance.
So we have two options. Either the patient has allergy reaction and you document, you clarify that, or they may have just intolerance for the medication. And then also you can clarify that in the EMR. And the idea from this topic, I'm going to just jump in. The idea is that patients who has true penicillin allergy, you need to identify them when they need penicillin type medication. You will switch to something different. We were just talking about syphilis, for example. Neurosyphilis, you need to give penicillin. But what happens if the patient has true penicillin allergy? Then in this case, you want to switch to something different, something like that. So the rest of the slides are just about how you fix that in the EMR. And as I said, it's going to be done from one EMR to another. So thank you so much. And I really appreciate your presentation. Thank you so much. This is great.
Opportunity. Thank you.
Yeah.
If there is any questions, please ask.
Any comment, any questions? Go ahead.
Okay.
If no more questions, we can open the floor for any updates, questions, comments regarding the fellowship, new ideas, your projects, your involvement, and please go ahead, either jump in or raise your hand. Thank you.
Hello, everyone. Again, I will want to tell you that the group for cancer test, screening test was initiated, but until now there is no specific plan for it. But we made the group.
So you want to build an app, is that correct?
Yes. Application about cancer screening test. Yes, we formatted a group. We made a group, but we will start the next week, inshallah.
Sounds good. So my suggestion is to identify some of the group members to handle the task differently. So one of the first task is to look at what's available nowadays and see if there is an app that similar to what you think, and see if there are areas where they can improve on this app. Test the app, see if there are areas that they did not cover. So you have two options. Option number one is to create an app that's different than the one that's available with some similarity, or an app that covers something that is not covered by the current app. So let me know. And then the other people in the group, they can work on getting the data, getting the references, or working on the app, or developing a plan for sharing the app in the future when it's developed and shared in the App Store. Thank you so much.
Thank you.
Thank you. Good. Dr. Amal, Omer, go ahead.
Hi, I want to know if there is still a chance to be part of the cancer group or no chance anymore.
Until now, we are 12 members. If there is any capacity, I will tell you, inshallah.
So my approach to the app development, I don't think there is limitation. In the past, we limit the number to 10 or around that number, because when we submit a product like an abstract, we want to limit the number of users or participants, because when we register for the conference, some of the conferences, they have only 10 or less spots for the authors. So if we are 15 in the app and the abstract writing and the abstract is accepted, some of these 15 will not be listed in the conference, and this is not fair for the group. So this is why we want the projects, if you are writing an abstract or if you are writing a manuscript, to be limited. And then these people, 10 or less, they will work together, identify tasks, and they can divide them. But in the app development, I think we don't have to have a limitation. It depends on how active the people are. So like Amal is interested and she might have some time, you can divide some tasks for her. Or maybe she is planning to do step 3. So she's not available now, but she will be available after. So her task will be at that time to spread the word and get as many to test the app and see if there is any feedback so that we can improve the app, something like that. So each one in the group, they can have some part or role to play.
How many person? How many person?
No, there is no limit. You decide. The leader can
Okay.
decide. And again, depending on how much task you have, and you can identify people in the group, divide the task so that each group in this team will have something to work on.
Okay.
For example, if you want, you can ask 2 or 3 to look at the App Store, either Google or Apple Store, see what's available, like similar to the app that you want to develop. And if they found a lot, then you can ask the group members to test each one and then give you feedback on what the area of that's not covered or area for improvement, or how to build the app, like the main key point. Then you develop the task and then divide it between the members.
Okay.
That makes sense. Thank you.
Thank you.
Thank you.
You're welcome. Anyone else? Go ahead, Dr. Fatima.
Hello, how are you, Dr. Nader? How everyone?
Very good.
I just have a question. I'm from the Orange team, and we were ready to publish our research about the public access to public defibrillator. So we just want to know how we're supposed to write exactly the affiliation.
Oh, the affiliation, it's just going to be the Department of Family Medicine, Division of Geriatric Medicine, and then MSU, Michigan State University. Okay. So the program is affiliated with this. If there are some members or authors from different institutions, let's say someone is working in New York State University, something, then they can also add that as their institution, and they can be into institutions. So they will be with MSU and the other institution, for example.
Okay. Okay, thank you so much.
You're welcome. Thank you. Anyone else? Any other new ideas for projects? Any comments? Anything for the fellowship?
Assalamu alaikum wa rahmatullah.
Alaikum salam wa rahmatullah. Dr. Rayan, go ahead.
Dr. Nader, how are you?
And
My name is Rayan Omer. I recently joined your group. First of all, I'm so impressed by the idea of this group, and I'm so impressed by your cooperation with your group members. And I'm so grateful that you gave me this opportunity to be a part of your group. It's like the third week for me. I'm just wondering if I can join to a subgroup. I don't know if I can do this at this time or allowed for me to do this at this time, but I'm so like excited. I want to join to a subgroup, and I want to be an active member. So I'm asking if I can do this thing. I sent you an email like 9 or 10 days ago asking for this thing. I will be so grateful if you give me this opportunity again. And thank you so much for your great job. Thank you.
thank you so much for your comment, Rayan. And I'm sorry I'm late with my responses, but it's time of the year.
I'm sorry, but I want to say something.
Let me just finish and I'll let you go. So we will form a team for newcomers or new fellows who joined recently. So you will be one of the new team. So hopefully soon you will have an email with some details as far as which team and who will be leading that team and what's the task, and you can help us with this fellowship.
Okay, thank you so much. Okay.
I hope I answered your question, Izada.
I just wanted to say that I'm interested in the subjects presented by the Great Group. So my question was if I can just, I have the opportunity to join to the Great Group, but I think there is no opportunity right now, right? I have to be in a new group because I recently joined to this group.
It's either or. If you prefer, let's say you have someone in the great team and you want to really work with that person, we can add you to the great team. So
thank you so
no
much.
problem. Just send me an email, remind me, I'll add you to that team.
Okay, thank you so much, sir. Thank you.
Thank you. Go ahead, Dr. Naud.
Yeah, I just want to answer to the previous caller, Dr. Ryan. So we'll try to figure out if we have a team with less group members, we'll try to connect her with the group which have less group members. If not, we'll try to assemble a new group who haven't joined any color group. Then we'll combine them and form a new group so that it will be more compiled and more appealing for her, so that it will be more like compiled and context in such a way that they will have a group which have recently joined the telegeriatric research fellowship, maybe after May, June, or July. So I will try to figure out and ask all the group members if they have maybe 1 or 2 less group members. So we'll try to join her to that group. If not, we'll form a group in which the new fellows who have joined this telegeriatric research fellowship haven't joined any form group, so that we'll form a new group and we'll form a new group that is composed of people who have joined this fellowship later in the campaign. Thank you.
Thank you so much, Dr. Naud. Go ahead, Dr. Amal.
Thank you, Dr. Nader. So I just wanted to ask about, should we proceed with the case reports that I sent to you in the email? I'm not sure if we can proceed with the publishing process.
Go ahead. Yes, I think you can go ahead.
Okay, sounds great. Thank you so much.
Thank you again. And good luck.
Thank you.
You're welcome. Go ahead, Dr. Maha or Mafaz. Sorry.
Hope everyone is doing good, and thank you for the informative presentations today. I don't have an update, but I just had a question regarding the availability, or is there opening for newcomers, or I think I missed the deadline for the newcomers because I had met 2 students that were interested in joining your program, and I'm not sure like the newcomers, is it open or not?
So usually we try to start in let's say March, April. But my advice usually to the newcomers is that if they are recently graduate, let's say, or if they are planning to take step 1 or step 2, I'd rather wait and take them later after they pass the test, because the important part when you apply to residency program, at least in the past, they look at your scores. So if you want to advise these newcomers is focus on the steps, pass them, and you will have time to do other stuff. Among this is the research. We can help you with the research part, with doing other development of other skills. But the main one is passing and having good scores, at least in the past. So we can accept newcomers, and usually officially in April or March, April area. But now we want to accept these who are interested in doing some research. Currently, they already passed the exams. They are just ready for the residency. And so if they have time and effort and energy, we will welcome them. And then hopefully we can divide them into some groups and teams so that they can understand the concept of this fellowship, as well as if they can work on some projects so that they can work on new ideas or new projects that can help them develop and improve. Thank you.
Thank you, Tanat. Thank you for explaining.
So feel free to refer them if they are ready. If they are still preparing, I'd rather advise them to wait.
Yes, I'll advise them to wait because they still did not finish the step 1 and step 2. Hopefully in the future. Thank you so much.
Sounds good. Yeah, thank you. Any other comments, questions, new ideas, any suggestions? If you do, let me know, and you can send me an email, contact me, call me, text me. I'll be happy to answer and help as much as I can. But thank you so much, all the presenters from today. And I'd like to thank you. Go ahead.
Hello, sir.
Niluka, go ahead.
Sir, good evening, sir. I am Niluka. Sir, I want to know about the research track. I applied for the one program. They send me the second application. They say you apply for the research track. Can you explain me a little bit, sir, about that research track program?
I'm not quite sure. Let me open the floor for any of the fellows. Anyone has any idea about research track? So let me just maybe try to understand your question. Is it you are applying to residency, like family medicine, internal medicine, something like that? And they ask
I applied. Sorry, sir. Go ahead. Sorry, sir.
And they ask this question in the ERAS application or somewhere you got this question?
No.
Or?
No, sir. I applied for the psychiatric program. They send me the second application, psychiatric research training program. Psychiatric residency training program, research track. They send me the second application, sir.
So is that they accept you, but they want you to fill the application for that position?
Yes, sir.
That's good. Congratulations. So
thank you, sir.
Yeah, if that's the case, maybe you will be working sometimes, at least my understanding in the fellowship where I did my training, they have either clinical, that means you are accepted for the service where you will be trained, seeing patients and educational part, or there are other type. My type was just purely clinical, it was 1 year training fellowship. But the other type that I didn't go through, other programs offer, is clinical plus research. So it's kind of 2 years program where you will be working clinically in the hospital, other facilities, just for the clinical training, educational part. And then the next year or third year will be only research part. So most likely this is what's happening in your case. They want you to work clinically. You're going to see some patients, but in 1 year or so, they will give you some time off so that you can work on research project or research activity for that time. So if you want to share the application with me, I can guide you through if I can be of help. Otherwise, this is my understanding is they want you to.
No, sir. I will send it to you, sir. I will send it to you. Thank you, sir. Thank you for your great help.
No problem. Congratulations again. Which program did you?
It is the UCLA, University of California, UCLA, Los Angeles.
A good one. Excellent. Congratulations.
Thank you, sir. Thank you for your great help. Yeah, thank you, sir.
Welcome. Yeah.
Is it okay to send it that link with user to user? I got the link.
If you can send me the link by email, I'll look at it and then give you my feedback. If
thank you, sir. Thank you. I will send just now, sir. Okay,
sure.
I'm going to send it, sir. Thank you very much, sir.
No problem. Congratulations again. Thank you.
Thank you.
Anyone else? If not, then I'd like to thank you all attendees from today's meeting and those who will come later to look at the recording. And thank you again for these great presentations. Thank you all, and we'll see you next week. Have a wonderful day or night. See you. Assalamu alaikum.
Thank you so much.
Thank you.
Thank you, everyone.
Thank you, Dr. Nader.
Thank you.
Thank you, Dr.
very
Nader.
much.
Assalamu alaikum.
Bye-bye.
Thank you.
Thank you.
Thank you so much, Dr. Nader.
Thank you again, and I really appreciate it.
Thank you very much.
Thank you so much.
Thank you, Dr. Nader.
Thank you.
And thank you for uploading my LOR. Thank you.
Oh, sure. Yeah. Good luck.